It's an absolute pleasure to give this presentation, and I want to welcome everybody who is attending this webcast. And so what I want to do is try to give you an update where we are with some focus on anti-angiogenic drugs, going from preclinical evidence further towards clinical evidence, and where we are going in the near future. So let's start with the preclinical evidence, why angiogenesis is still playing an important role in the mechanism of action of different cells with the maintenance of cancer, but also the possibility to target some of these cells. We have been focusing on endothelial cells in the past. We have focused on tumor cells, but what you see here, it's more an interaction between endothelial tumor cells and also immunological cells like the dendritic cells, the macrophages. So it's an interplay which will be important in the near future to target this type of cancer. As we know, angiogenesis in general in cancer is important because you need adequate supply of nutrients, oxygen. You have the removal of waste products, and also it's a possibility to metastasize from the primary tumor to other places and to get, for example, in colorectal cancer, the fact that you have liver metastasis and lung metastasis. On the other side, it's also important to underline that in normal tissue, it's important that we have that process of angiogenesis because it's an important step in the developmental process of different tissues. Looking to the situation in colorectal cancer and the fact that we are making a switch from a pre-malignant situation, like for example in the polyps, going to a malignant situation and then further the tumor growth and the invasion, and at a certain moment you have the seeding of tumor cells to different sites in the body where they will stay for a certain period, and at a certain moment they get activated again. So in different stages of the process going from primary tumor towards metastasis, you have an important role of angiogenesis. The interaction between the different cells, and here you see the endothelial cells, the inflammatory cells, and the fibroblast, and also the tumors, it's a question of cytokines. It's a question of interaction between receptors and these cytokines. For example, we all know the story of VEGF, PLGF. We know the story of interleukins, which might play a role in the interaction between the tumor cells and the inflammatory cells. So trying to interact with these factors and also the binding to the receptor is a basis for a new therapeutic mechanism. Is it easy? The question of angiogenesis and cancer? No, because what we have seen over the years, if you look back, we started to use bevacizumab more than 10 years ago in colorectal cancer. And at that moment, there was a strong hypothesis if we could influence the vasculature of the tumors, that we could cure most of our patients. Although we have benefited of these drugs, it's for sure not the only mechanism that maintain the tumor, and also is the factor that will have an increase in the tumor size and also the metastasis profile. We now know that there might be even a place of an interaction between anti-angiogenic drugs and, for example, immune therapy. So it's a very complex interplay where you have the inhibition of epithelial growth, where you have inhibition of bone marrow-derived progenitor cells, you have the normalization of improved vascularization, there is the tumor drug accessibility, the vascular constriction, direct effect of the antigenic drug on the tumor itself, the disruption of the cancer stem cell niche, and, like I already said, the possible interplay with the immune function. What are the drugs that we have currently available that have an impact on that pathway, on that VEGF-driven pathway, on that angiogenesis mechanism? So we have different options, and also in colorectal cancer, especially metastatic colorectal cancer, most of these drugs prove to be efficacious. So we have, first of all, the oldest one, bevacizumab, which is an anti-VEGF-A antibody, which interact with the receptor, VEGFR2. We have aflibercept, which clearly has a broader mode of action than bevacizumab, targeting not only VEGF-A, but also VEGF-B and PLGF. We have seen recently some data on ramucirumab, which is an anti-VEGFR2 antibody. And in later lines, regorafenib is a small molecule with a broad mode of action on different receptors, but also on the immune function. Focusing on aflibercept and bevacizumab, we know since years that bevacizumab is a humanized monoclonal antibody. Like we already said, it prevents the binding of VEGF-A to the receptor, and it results in the inhibition of the activation of the downstream signal pathway. Looking to aflibercept, it's another molecule. It's a fusion protein, which fusion protein of key domains from human VEGF receptors 1 and 2. It blocks multiple human VEGF-A isoforms, not only VEGF-A, but also VEGF-B and placental growth factor, PLGF, and it has a high affinity of VEGF-A, and that's the reason why there is an interaction with the receptor sequence. We have two molecules, bevacizumab, aflibercept. Is there a difference? We already said that the interaction with the cytokines, with VEGF, is different. It's broader with aflibercept. But can we prove this in some mouse models? And this is an example of some years ago, where you have PDX models. You have the placebo group. You have the ones treated with bevacizumab for 1 to 2 weeks subcutaneously. Then there was tumor escape under bevacizumab treatment, and one group received bevacizumab afterwards, and another group received aflibercept. If you look to the right side, it's clear that you have a better effect of controlling the tumor if you switch to aflibercept, which is the blue curve, in comparison with the continuation of the bevacizumab treatment based on the measurement of the tumor volume. The gray curves is the one that received placebo, where you clearly see a total escape of the tumor. So this is preclinical evidence. The next step is, what is the clinical evidence? Do we make progress in the treatment of metastatic colorectal cancer? For sure we did. If you look to the overall survival of metastatic colorectal cancer today, most of our patients are living more than 30-40 months, and exceptional cases even reach 7 to 10 years with the metastatic disease. And the reason is that we are trying to target different levels of the mechanism of metastasis, the mechanism of growing of the tumor, not only by inhibitors of the VEGF signaling, but also EGFR inhibitors, and very recently, on the right side, the interaction with the immune system. These are data from the Belgium Cancer Register, and if you look to the different stages, in blue the stage 1, in gray the stage 4, different age groups. But what is important, especially in the stage 2 and stage 3, the chance that these patients will have metastasis during the evolution or during the follow-up of the disease is very high. So that means that still a huge proportion of our patients with colorectal cancer at a certain moment will have metastasis. Today, on a population of 11 million, we have around 8,000, 9,000 new cases of colorectal cancer in Belgium. The clinical presentation is quite heterogeneous. Also, the tumor characteristics is very heterogeneous. For example, on the left side, you see different situations of metastatic disease, where in one case, at the bottom, probably you will go for surgery. If you look in the middle, probably this is a patient that only receives chemotherapy or a combination with targeted therapy. Also, on PET scan, it's clear that these tumors are active and can metastasize at different levels. For example, you have on the right side a big muscular metastasis in a patient with a history of colorectal cancer. And so this means if you look to the algorithm, you need to decide at a certain moment with a multidisciplinary team whether this patient is a patient with diffuse metastatic disease, where you try to control the disease as long as possible, or when you have a patient with limited disease, where the question is this a resectable patient for the metastatic lesions, or is this potentially resectable? And in that situation, you need to answer the question, what type of chemotherapy is the best way to treat upfront, either to have a good response or trying to have control of the micrometastases which are in that patient located at different sites. So depending on the clinical presentation, already you need to decide what option to propose to your patient. One word on the diffuse group. This is still the majority in most of the countries. But what we see currently with very active combination, that in some cases a patient goes from diffuse metastatic disease to limited disease, and then is the question, is surgery a good option in that given patient? In the field of biomarkers, the only indication to use biomarkers currently is if we need to decide to treat our patient with anti-EGFR, yes or no. And this is a story of 10 years of research and clinical work, where we started at a certain moment to treat these patients with anti-EGFR in all patients presenting with metastatic colorectal cancer. At a certain moment, we had the information that KRAS could define the ones that were not good candidates to be treated with anti-EGFR, the ones with a mutation in KRAS. And nowadays, standard of care is to determine the RAS status and to have a decision whether you can treat in a combination with chemotherapy, mostly with one of the anti-EGFR drugs. So we came from a group of 100% of the patient treated towards nowadays a group of 40%, and 60% are not good candidates to be treated with anti-EGFR. So making a difference and making the choice of treatment can already be based on mutated wild-type RAS, and you see that in different situations, first, second, and third line, you have different options available. And for example, in second line, you have chemotherapy in the mutant, you have bevacizumab, aflibercept, and in some countries, ramucirumab in combination with chemotherapy. And in the situation of a wild-type tumor, you also have the option to combine with anti-EGFR. This is a clear study in 2016 published, where they looked to the different subgroups based on not only KRAS status, but also BRAF status. And what you see here is that if you have a patient with a mutated BRAF tumor, which is in red, prognostically, these patients are clearly doing less good than the other groups. The groups with a KRAS mutation in codon 12 or codon 13 with non-mutated BRAF are somewhere in between the BRAF mutated and the fully wild-type population. At the bottom of this slide, there is also the introduction of mismatch repair gene status to see whether there is also a difference in outcome. And if you look to the sporadic cases with mismatch repair genes deficiency, it's clearly in blue that they are doing better than the mutated KRAS, and also especially in comparison with the green curve where you have the BRAF mutated tumors. So prognostically, based on that biomarker panel, you already can differentiate between different groups. And that's making the link to the group of patients that currently are having a benefit of immune therapy, the ones with MSI high tumors. This is the only group currently that is having a clear benefit in colorectal cancer. And so this is seen not only in monotherapy at the bottom of this slide, but also if you see the combination treatment at the top of this slide, where you see the combination of Nivo plus ipilimumab is clearly doing better than Nivo alone. And the second important point is in the group which are candidate, and it's around 5% of the total population of our patients with metastatic colorectal cancer. If you have a response, mostly this response will maintain for a long duration. So this is the importance of having immune therapy available. First of all, selection of the patient based on MSI status. And second, if you have a response in this patient, normally you have a long duration of response. Another important finding the last 2 years is the impact of the location of the primary tumor on the outcome of the patients with metastatic colorectal cancer. And my team, one of my PhD students, did a lot of work on that. We looked not only in first line, but also in second and in third line. And the first point is that there is a clear difference in incidence of location between left and right. 75% of the tumors are located on the left side, 25% on the right side. This is not only a finding in our data set, but in general in literature. So the next question is that location of this primary tumor in ROS wild type prognostically and predictively important? And the conclusion is there that if you have a patient with a left-sided fully ROS wild type tumor, that in that patient, first of all, the prognosis is better than on the right side, and second, that this is a prediction in favor of using the anti-EGFR treatment. The situation is different on the right side, small groups, very difficult to draw final conclusions, but in general the message is if you have right-sided tumor, ROS wild type, probably it's better to use chemotherapy plus an anti-VEGF treatment, with one exception. If you want to obtain a high response, probably in that situation there is still a place to use the combination with anti-EGFR treatment. And so based on all this information, we can do a workup to decide what is the strategy. You have the clinical information, performance status, the primary in place, location of the primary tumor. You have the molecular profile, RAS, BRAF, MSI, and HER2. You have imaging information. Then you have the multidisciplinary team discussion, and then making the decision whether this patient is resectable or unresectable, and based on the molecular profile, based on the location of the primary tumor, you can select one of the treatment options. It's also important to mention that it's not only about chemotherapy, that it's not only about systemic treatment. At MTD, it's important to have a discussion on all treatment options, not only at the moment of diagnosis, but at certain important steps during the evolution of the disease. For example, if you need to decide after 4 months of treatment in a patient with a good response whether surgery is an option, yes or no. And so all this information is also summarized in one of the guidelines that is available, and this is a joint effort of ESMO and the Japanese colleagues, where you see on top the performance status of your patient, fit or unfit, then the question on the aim of the treatment, is it cytoreduction or disease control? Then you have the molecular level, RAS, BRAF, and probably we need to integrate MSI. And at that moment, you need to decide what are the best options to come to the aim of your treatment, to try to reduce the tumor volume, to try to reduce the number of metastases, and to go for surgery or to try to control the symptoms. This workup needs to be done, like I already said, at certain time points during the evolution of the disease. And so we take into account 9 different factors to make that decision. Of course, you need a treatment with efficacy. You need a balance with safety, especially if you go further during the evolution of the disease. Tumor characteristics, biomarkers, but also patient characteristics. Previous treatment and patient preference might play an important role in your decision algorithm. How many patients will we treat? Most centers currently are treating patients in frontline. Probably not 100%, but between 90 and 100%. And you see over the lines, you lose around 20-25% of your population. But what is remarkable is here in this publication that still half of the patients are still candidate for later line of treatment. Going further into the treatment lines, you see that the chance of clinical benefit is decreasing. But in colorectal cancer, in metastatic colorectal cancer, the outcome will be influenced by the continuing of care. So it's not only the first line which will determine the outcome, but the addition of the different lines which the patient will receive. And so chemotherapy sequence is important. Do we have an answer? What is the best sequence currently? We don't know. This is an old study where we had 14, 15 years ago the discussion on what is better, starting with FOLFIRI or FOLFOX or vice versa. The conclusion of that study is that either you can start with FOLFIRI or you can start with FOLFOX. It's a question of patient profile, it's a question of toxicity profile, whether you, and also reimbursement, which influence your decision. Also, the way we treat our patient changed over the years. At the moment that you start in frontline and you have a good response, you can have 3 different options. The old-fashioned way to treat until progression, the one introducing with maintenance, especially if we start with oxaliplatin. We take out the oxaliplatin and continue 5-FU. And another option is a stop and go, where you closely follow your patient after stopping the treatment and see what is happening and reintroducing the same regimen when the patient is again progressing. Moving to the second line situation or later line situation, like I already said, your choice will be determined what was the previous treatment setting, what were the drugs that were given. For example, you can have first-line metastatic therapy, treatment until progression. You can have a rapid progressor under adjuvant therapy. You can have a patient with induction therapy, going to surgery, and then continuation of therapy. You can have the situation of maintenance, and in last situation, the patient can stop first-line treatment due to toxicity. All these patients will go to later lines. And depending on what happened in the front line, you will see that you have different choices based on, for example, the patient received oxaliplatin or the patient received irinotecan. Over the lines, going further in the evolution, response is less important. It's more the balance between quality of life and having an impact on progression-free survival and overall survival. And so, if you go beyond first line, depending on the first line, which is in blue, based on your molecular profile, you clearly see that you have different options also in second line. And so this is an overview of the results that we obtained in second line studies based on the combination with chemotherapy and anti-angiogenic drugs. What we see here is that most of these combinations had an impact on the median progression-free survival in favor of the combination. What we also see here, and it's very difficult to have inter-trial comparison, but for example, the combination aflibercept plus FOLFIRI has a response, even in second-line setting, of 20%, and also, what is also important, a significant impact on the median overall survival. And this is shown in this curve, where you clearly see that over time, you have a split in favor of the top curve in blue, which is the aflibercept arm, versus the one that received all the FOLFIRI in this situation. If you have a phase 3 study and you go to the real world situation, it's important also to see whether these results can be confirmed in that situation, and do we have the same toxicity profile in the real world situation. So we have different studies with aflibercept where they looked into this real world usage of aflibercept in combination with FOLFIRI. Depending on country to country, there is between 30% and 60% of prior bevacizumab use. In some studies, the patients received anti-JAV1 upfront, and if we look to the median progression-free survival, it's clear that it's in line with the randomized phase 3 study, the VLUR study, which had a median progression-free survival of 6.9 months. Also, the response is comparable with the VLUR data of 20%. Toxicity. All combinations, all drugs have adverse events. Aflibercept is working on the angiogenesis pathway. You can expect hypertension, proteinuria, thrombotic effects. If we compare the data with the VLUR study, in comparison with the real-world data, it's clear that with more usage, the fact that the oncologist knows the drugs very well, that the incidence of side effects is in line with the VLUR study and probably lower than we can expect based on the randomized phase 3 study. Can we have a distinction in populations that are candidate to receive aflibercept? This slide shows you the fraction of patients that receive bevacizumab up front, no bevacizumab, so no antigenic drug in the front line. And if we look to the outcome of these data, on top overall survival, at the bottom progression-free survival, it's clear that there is no difference either in the group bevacizumab treated versus the one that didn't receive anti-angiogenic drugs. So even after failing bevacizumab, aflibercept is an option. further work tried to find other subgroups. And one of the subgroups, and this is published in 2015, when you have a rapid progressor after adjuvant therapy, meaning less than 6 months, that's probably not a good candidate to be treated with a combination with aflibercept. And so coming from the initial VLUR study, going to the best responders, meaning with the highest overall survival, with the best progression-free survival, and with the highest response, it's based on a post hoc analysis, patients in good performance status, with a low number of metastatic sites, and with the ones with fast relapse after adjuvant therapy, so meaning coming to 66% of the total population, this is the group with the best responders under treatment with FOLFIRI and aflibercept. This is second-line situation. So the clear message is aflibercept in combination with chemotherapy is a good option in the treatment of patients progressing after a first-line setting. If we move further to the later lines, third, fourth line, we also have different options. You have the small molecule, regorafenib, different studies. On the left side, the phase 3 studies. On the right side, real-world data. The key message is the drug works. The drug works in a fraction of patients. It's a question of having control of the side effects. And in the beginning, it was a discussion on what is the right dosing. And most of the physicians that are now using this drug probably go for the step-up procedure, where you start with low dose, after 1 week go to 120 milligram, and after 2 weeks go to 160 milligram. Continuing of care is important. What is the reason? This is the reason. What we have seen that based on data on survival, it's clear that the death rate in most of the countries is going down. This is due to better treatment, multidisciplinary approach, new drugs such as aflibercept, but in certain countries it's also and already the effect of the screening programs that are in place. So hopefully we can go down with these curves over the years and have a clear impact on the mortality of our patients. And the sequence, like I already said, is not a sequence of guidelines. It's an individualized decision where you need to take all the possibilities into account to make the best strategy in a given patient. And therefore, I want to clearly to stress the importance of the multidisciplinary discussion, not only in the patients that need surgery, but also the ones that need a decision on the treatment options. And that is what you see here, that it's a continuing of care where you have the integration of different possibilities into the strategy of the patient. And so if we look back on treatment with 5-FU, 5-FU plus leucovorin, and the new drugs such as bevacizumab and aflibercept, it's clear that we shift the curve up to a better survival in the majority of patients. Can we have more effect in the future? Yes, with new drugs, and especially in the mutated population, there is a clear challenge, but also with the integration of new biomarkers. We have seen some data on RAS, BRAF, MSI. Mostly we need tissue, but probably in the future, we're going to use the liquid biopsy to have diagnosis, to have a prediction, and to have the follow-up of our patients. Do we have good markers in the setting of anti-angiogenic drugs? For the moment, it's very difficult, still difficult. We have some data, for example, if a patient is treated with bevacizumab up front, we see an increase of PLGF and VEGF-A levels, which might be a base to treat patients afterwards with aflibercept, due to the broad mode of action of this drug. Do we have other data that are coming for the moment? This is the biomarker program of the VLUR study, where you have the VLUR intention to treat patients, more than 1,200 patients, where you have the tissue samples collected of more than half of the patients, and NGS assay is performed in around 500 patients of the original population. And so what they did is looking for RAS, KRAS, BRAF, location of the primary tumor, and what has been the message based on this type of analysis, that in most of these populations, there is a clear benefit of treating these patients with a combination of aflibercept. So the key message is, based on this group of markers, the treatment is independent of the profile based on RAS, BRAF, and the location of the primary tumor. So coming to conclusion, treatment of metastatic colorectal cancer is clearly a continuing of care, but it's important to have all registered drugs needs to be available, but also based on evidence. Second, influence of previous treatment, not only on efficacy, but also on safety. Your decision is also influenced by comorbidities, especially in a population where you have an age group between 60, 70, 75. The preference of the patient is playing a role, especially if we have more and more oral drugs available. The goal of the treatment, shrinkage, control of the disease, and what is important, due to the different options that we have available, different safety profiles. At the moment that we had the introduction of immune therapy, we had to learn the side effects. So the knowledge of the oncological team is absolutely necessary. And so the question on what is the best biological to be used in the different lines, it's not a black and white situation. It's more a question of individualizing our decision. Thank you very much.
Thank you, Professor Peeters, for your excellent presentation. So, shall we start with questions?
Yes, please.
First of all, to summarize and to have a take-home message, is there an ideal patient for aflibercept? How does he look like?
It's a very difficult question. But for example, if you have a patient, first of all, I think you can exclude some patients based on the post hoc analysis that we did. Second, if you have a patient in good performance status that had a good control under previous treatment, either with bevacizumab or with chemotherapy or with an anti-GVAR, at that moment, and you want to switch to another anti-VEGF treatment with a broader mode of action, I think this is the ideal situation to treat this patient with aflibercept. If you have a patient that is, let's say, progressing very rapidly under a combination with bevacizumab, and again, you want to obtain a response, especially in the mutated population, with an anti-VEGF therapy, aflibercept is a choice better than continuation of bevacizumab in this given patient. In most of the countries, ramucirumab is not available. So it's a question of choosing between bevacizumab and aflibercept. And the last reason, if you look to the response rate that you can obtain with aflibercept, the response of aflibercept is clearly higher than the other anti-VEGF drugs in second-line situation.
Mm-hmm. We saw that aflibercept remains active after using bevacizumab in a first-line treatment. But what about aflibercept when EGFR inhibitors are used in the first line? We have no data from VELOR study, but now we have some real-life data.
Yeah. Based on the real-life data, it's clear that even after failing anti-EGFR treatment, you see that the efficacy of aflibercept is maintained. This is, of course, not a randomized study, but it gives you an argument that aflibercept has a place after failing anti-EGFR. A second important reason is that what we have seen that if you have anti-EGFR treatment in first line, then an anti-VEGF in second line, and then in certain cases have a reintroduction of anti-EGFR excuse me, in later lines, probably this is the best sequence to obtain the maximum effect of both antibodies.
Mm-hmm. But nowadays, still some global guidelines prefers bevacizumab over other therapy options in second-line treatment of metastatic colorectal cancer. What do you think is the rationale for that?
I don't think so. I think for the moment, and I think most of the updated guidelines leaves the option to use one of the antibodies. And like I said, and I clearly indicated that in my table, it's depending on a lot of factors which type of antibody that you want to use in a given patient. And to make the statement that you need to treat all patients with one antibody, and this is the golden standard, I don't think today, with all the knowledge that we have, that you can have an argument for this strategy. And especially if you look, for example, to the response of aflibercept in second line, it's clearly higher than what we have seen with bevacizumab.
So we need an update of guidelines. You mentioned Tuniga's GERCO study published 15 years ago, describing head-to-head comparison between irinotecan-based and oxaliplatin-based protocols without any significant difference in a first-line treatment. But in what situations would you recommend oxaliplatin over irinotecan protocol in a first-line therapy?
That's a difficult one. I think you always need to think, what is the aim of my treatment? How long do I want to treat this patient? And what are the second line and third line options that I have available? For example, if you want to have a good response and you treat your patient for a very short period, 4 to 6 months, you can go for oxaliplatin, because at that moment you don't have the problem with the side effect, which is very specific for oxaliplatin, is the neuropathy. If, of course, you want to treat that patient for a very long period, probably irinotecan is a better choice over oxaliplatin. Although, and I showed in one of my slides, if you are flexible, for example, you start with FOLFOX in combination with one of the antibodies, you can take out the oxaliplatin at the moment that you have response and reintroduce afterwards to overcome the problem of neuropathy. So depending on the presentation of the patient, depending on the situation, both options are possible. And I don't think one can make the statement that, for example, I'm going to treat every patient with FOLFIRI in first line, or I'm going to treat every patient with FOLFOX. Also there, you need some flexibility.
Would you say you are optimistic about new drugs being developed for metastatic colorectal cancer in the near future?
Am I optimistic? Let's say realistic. We had 10 years where we had the introduction of a lot of new drugs. Second, since 2-3 years, we have evidence in a very small subgroup that you have a place for immune therapy. The problem that I'm seeing for the moment, and I don't have a good answer, and I don't see drugs coming on board in the next few years, is the patient population with the mutated ROS tumors. Because there the options are very limited. So there we need absolutely new options for treatment of these patients. And so what I see for the moment that we had the golden years of introduction of new options, and for the moment we are more in a dip and we have to wait for new mode of actions, new combinations, especially in the mutated population. So I'm realistic, I'm not optimistic in the short time period, because I don't see clearly new trials which are making the difference with new molecules. What we will see probably is, for example, in the BRAF mutated population, there we will use in the future triple targeted therapy to overcome the resistance, but in the RAS muted population, there is an absolute need for new options.
Do you see a role of HER2 amplification as a prognostic and predictive biomarker and a clinically actionable target, although in a small number of patients?
Yeah, but what we currently do, especially if the patient is becoming resistant, at that moment we are testing for HER2 amplification, and if we have the drug available, then we're going to treat that patient with, for example, a combination of trastuzumab. Is this strong evidence? It's not a phase 3 randomized study, but I have seen very interesting data, and especially if you don't have a clear option and you have that amplification, it's a reason to try and to see whether you can have a control of the tumor with a trastuzumab-based regimen.
So, Professor, if someone asks you, do we need targeted therapy for every patient?
No.
What will you say?
No. I think you need, for example, I don't think that every patient needs targeted therapy. And I'm still a believer that in certain patients, you even can start with oral therapy with capecitabine, for example, and to see what is happening. The most important part of the discussion is a good profiling of your patient, a good discussion of the multidisciplinary team, and a good follow-up of your patient. And if you have these three done, and you start with soft, between brackets, soft therapy, for example, capecitabine, then probably you are having a good therapy for that given patient. So again, this is clearly making a statement for personalized decision and not a generalized decision.
What do you think, how will bevacizumab biosimilars impact treatment of metastatic colorectal cancer?
Bevacizumab biosimilars. I think the biosimilars, it's not only in colorectal cancer, it's in every type of cancer that you see the introduction of biosimilars. First of all, in most of the countries, it will broaden the indications, but like I said in my final slide, you need evidence to use this type of drugs, even the biosimilar, based on evidence. If you don't have in third or fourth line evidence that bevacizumab is working, I don't think it's because you have a biosimilar available that you need to use that in that indication. That is the first statement. The second statement is, and this is an issue in most of the European countries, it's a question of economics also. If you have a treatment which is similar than other treatments, you need to have a good balance. What is, from an economic perspective, the best way to go? And so it will change somewhat the field of treating patients with metastatic colorectal cancer. But for me, still, the priority is the evidence in a given situation. And secondly, to try to have an individualized decision on all the factors that we have available. And to coming back to your statement from where to use bevacizumab, I don't think you can say that bevacizumab is the one antibody that we're going to use in every situation and in every line of treatment.
Can we suggest and use aflibercept plus FOLFIRI combination of first-line treatment?
Well, the problem is that we don't have any data. So that is a difficulty, because if you start with FOLFIRI, it's very difficult to support aflibercept in second line. So you need to think about aflibercept as an option in second line and start with FOLFOX as a frontline treatment. So to support today the use of aflibercept in first line, there is no evidence, no supported data to make that statement for the moment.
Finally, can you describe us how your multidisciplinary team works? Does every single patient need to be presented at the team initially and when you change the therapy between lines?
Yeah. So first of all, we have a team meeting every week with surgeons, radiation oncologists, with pathologists, with radiologists, gastroenterologists, and oncologists. Second, we discuss not only the patients that are candidates for surgery, but also the ones that needs therapy, systemic therapy. And third, what is the guideline if a patient needs a treatment change? At that moment, normally we discuss again the patient at a multidisciplinary team meeting. The reason why this system is working very well is the fact that more than 10 years ago, the government made a decision that every patient needs to be discussed at a multidisciplinary team meeting, because, first of all, these data are linked to the cancer register, and second, there is a financial incentive for the persons who are attending this multidisciplinary team meeting. So it's a combination of factors why we are discussing very intensively almost every patient at a multidisciplinary team meeting.
Thank you, Professor. We will try to do the same.
With pleasure. If you need help, don't hesitate, because I know that dossier very well.